My name is Don Doddridge. I'm the president of the American Association of Blood Banks. I would like to welcome you to our first live AABB video conference via satellite. The topic today is Special Serologic Techniques. Our moderator is Kathy Carlson, MT, ASCP, SBB. Kathy is the Assistant to the President for Educational Services at Gulf Coast Regional Blood Center in Houston, Texas. Please welcome Kathy Carlson, the Chairperson of the Continuing Education Committee of the American Association of Blood Banks.
Thank you, Don. And I would also like to welcome everyone to the first live video conference of the American Association of Blood Bank, produced by the Continuing Education Committee. We have with us today as our speaker and demonstrator Marilyn Moulds, who is the Director of Consultation and Education at Gamma Biologicals Incorporated in Houston, Texas. Our topic today will be special serologic techniques. We will first demonstrate and discuss various aspects of two red cell separations, and then we will ask you for questions, and we have an 800 number for your convenience. The last part of the program will discuss low ionic strength salt solutions, and after we get through with that discussion, we will open it up for future questions. Marilyn will now discuss and demonstrate the two red cell separation techniques. And to begin, Marilyn, perhaps you can explain the purpose of the red cell separations.
The purpose of both techniques is to recover autologous red blood cells from transfused patients. The patient's separated red cells can then be phenotyped, which is valuable in cases where patients are developing alloantibodies to donor red cells. The red cell separation techniques can also help determine whether a direct antiglobulin test is positive due to bound alloantibody and/or autoantibody. If, due to a warm autoantibody, the autologous red blood cells can also be used for autoabsorption. The two very simple techniques I will demonstrate today are Micromedicate centrifugation and hypotonic washing.
Marilyn, what is the principle behind the Micromatic centrifugation separation technique?
Red blood cells of different ages have different specific gravities. Red cells, when released from the bone marrow, have a specific gravity of approximately 1.078. Upon aging, the specific gravity increases towards 1.114. When blood from a recently transfused patient is centrifuged in the Micromatic tubes, the younger reticulocyte enriched, or the autologous, patient red blood cells will be lighter than the older patient and donor red blood cells. These can be recovered from the top 5 millimeter portion of the tubes.
Would you please demonstrate the technique for us now?
Certainly. And if you would like to, those of you in the audience may follow along on your first handout and make notes as we go along. The materials you will need are a freshly drawn anticoagulated red blood cell sample from the patient, non-heparinized Hematocrit capillary tubes with an inside diameter of 1.1 to 1.2 millimeters and length 75 millimeters. You then need sealant, and we have two types here today that I could use either one. Seal Ease from Clay Adams, and then Mini Seal. But whatever type of sealant that you have available can be used. Centrifuge the 5 or 7 mml tube of anticoagulated blood and remove most of the plasma. And to speed it up today, we've gone ahead and taken the plasma off the tube. Wash the red cell sample once with saline and centrifuge for 5 minutes. And again today, to facilitate the procedure and to get it to go more rapidly, we've gone ahead and spun down the tube with saline. Aspirate the saline from the red cells, but do not remove the top portion which contains the reticulocyte enriched portion. Mix very carefully, and the hematocrit should be about 90%. Mix very carefully, and then fill the Micromatic tubes. And this takes practice. There are two ways to do it. I find that this seems to be the easiest, is to fill from the pipette. Do not fill to the very end. And then I tilt the tube and do not let it go down to the bottom, and then put it into the clay. And be sure that the clay is packed in, because you don't want these red cells spinning out when you put them in the centrifuge. I'll do one more here to show you again. Another technique is that some people would use the actual tube and not use the pipette and tilt the tube and have it go by gravity. But I find that that's more cumbersome, and as you get used to your pipette, you can do it quite easily using this method. Again, tilt the tube, but not to the very end. Pack it, and if you find that there is a little bit of blood on the end of it, you can wipe it. You place it in a Micromatic centrifuge, and now this is different than the one I have. The one I have has 24 slots, but you put it with the clay end, of course, facing out, because you're going to spin it down.
Assuming that you had a choice then of how many tubes you might load, if you weren't so limited, how many would you want to load at one time?
Well, what I do is, like our centrifuge holds 24. This one only holds 6. I would normally go ahead and charge all the capillary tubes, because it would depend on how much testing I would have to do, and it's better to go ahead and have them already filled. But you may only need 1 or 2 of the tubes, depending on whether the direct antiglobulin test is positive or negative. So it's individual cases, but I tend to go ahead and spin all of the tubes. Now, we're not going to spin today, but you would spin it in the Micromatic centrifuge at 13,500 times G's for 15 minutes. So you put it in the centrifuge, and then you go back and get your tubes ready. Okay?
I see you have some files there.
Yes. These are our gorgeous files, and this little card was made up very nicely for me. These are 2 types of files. I say this is the female file, and this is the male version. I like to use this particular file for etching the tubes. Now, I've spun down some tubes already today for us so that we could go through this rather rapidly. What you do is, ignoring the hemolysis at the top, and this hemolysis can occur because we have only washed the cell sample one time. Now, if you don't want to deal with that hemolysis, you can go ahead and wash the cell sample 2 or 3 times before you begin. But you etch 5 millimeters from the end of the red cells at the top of the tube, ignoring the hemolysis, and just etching the top 5 millimeter portion.
Do you get to where you can just eyeball that, or do you measure it every time?
Oh, no, I can eyeball it. As you do this, you get very experienced at doing it, and I recommend that everybody can do this procedure. You etch it. See how easily that came apart? I didn't have to do a thing to it. You then put it in a tube, and you label the tube. I label it the top portion, and I also have another tube that is labeled the bottom portion. Now we'll do one more here to show you. Again, taking the top 5 millimeter portion. Okay. Now you add normal saline to the tube, and you spin in the centrifuge for 1 minute with the Micromatic tubes inside the tube.
So the red cells spin out the bottom of the tube.
Right. Mm-hmm.
And what about the bottom portion? Do you keep that?
Okay. And you have this on the high speed. The bottom portion can be saved to do testing on in comparison with the top portion. You can etch the bottom portion 5 millimeters at the bottom here and collect that in a tube labeled bottom portion, okay? You can also have another tube here, and if you wish to, you can then take the whole bottom portion and put it into this tube, and if you want to do elution studies, and we'll talk about this in a minute, you can then do elution studies off the whole bottom portion. And this is important because if you have a transfusion reaction, for instance, you have now what I call concentrating the donor red cells and the patient's older cells into the bottom of the tube. And this way, you can then sort of have what we call concentrated red cells for an elution technique. And sometimes an elution on the whole blood might be negative, but then an elution might be positive on the bottom portion. Okay, then you take, and this is a little bit tricky and it depends, but you take the saline off, and if I had done a few more tubes, you would have more cells in the bottom. I'll put this down a minute. Can you see that? I'll turn it around this way.
Yeah.
Yeah, okay. Forgetting which way the camera is going here. And then you can see the cells have spun out into the bottom. And you transfer them to a clean tube. And then you rinse again with normal saline, being careful not to drop the capillary out. Then you fill the tube with saline and you spin it again for 1 minute.
So this whole thing really doesn't take very long, does it?
Oh, no, it's not long at all. And it is very simple to do. Oh, have to clear one. Okay.
So what kind of test might you want to do on these cells?
First of all, the primary thing that you do, you are looking for whether the cells have a positive direct antiglobulin test. So you make your cell suspension and you test the cells, and if the DAT is negative, then you have various options. Okay? In table 2-1, if you would like to pull that from your handout, we can go through the various test results that you might obtain. This handout, table 2-1, was taken from a chapter written by Virginia Hare entitled Selection of Techniques Useful in Differentiating Autoantibody from Alloantibody. It was in the workshop Selection of Procedures for Problem Solving, Arlington, Virginia, the American Association of Blood Banks, 1983, page 21. Okay, if we can have the first slide, please. The first example shows a positive DAT on the whole blood, the autologous red cells, and the older red cells, with no mixed field agglutination, and MFA standing for mixed field agglutination. The interpretation is autoantibody, drug-induced antibody, and alloantibody cannot be excluded if the patient has been recently transfused. The second example shows a positive DAT on the whole blood, a negative DAT on autologous red cells, and positive DAT on older red cells, but no mixed field agglutination. This is probably due to a warm autoantibody non-reactive with the patient's reticulocyte-enriched portion, but reactive with the older red cells of the patient. Branch et al. In 1982 reported on evidence for two distinct categories of warm autoantibody activity when using reticulocyte-rich or reticulocyte-poor red cell fractions. And the reference can be found in your handout at the end. They suggested that many warm autoantibodies may not readily recognize reticulocytes, perhaps because the corresponding antigen is not fully developed on the membrane surface. And I'd like to point out at this point that that's probably not the most common type of warm autoantibody that you would see, which is pretty good that it isn't. The third example shows a positive DAT on the whole blood and older red cells with mixed field agglutination. So you really do have to observe for that mixed field agglutination and examine it under the microscope. And the DAT on the autologous cells is negative. This is probably due to a transfusion-induced alloantibody. In the last example, the DAT on the whole blood and older red cells is positive and is weakly positive with the autologous red cells with mixed field agglutination. This could mean an effective red cell separation, or it could also mean that you have an autoantibody plus an alloantibody, and that's not too good. That's a little bit harder to work with. In examples 2 and 3, antigen phenotyping can be done on these autologous red cells that have a negative DAT. The autologous red cells that have a positive DAT in example number 1 can be treated with a chemical such as chloroquine diphosphate or even perhaps heat treated. And then if the DAT becomes negative, after treatment, phenotyping can be done on these cells then.
What about the age of these cells? Do you have to wait a certain amount of time after someone's been transfused?
Well, it is very important in this particular technique that you wait at least 72 hours after the patient has last been transfused. So that is one of what I would call the limitations. If they've been transfused within that 72-hour period, your cell separation will not be effective.
So it sounds like it's a pretty easy and simple technique.
Oh, it is nice. And really, this is not a reference lab technique. If more people would be doing this out in the hospitals, then you wouldn't have to be sending the samples to me in the reference lab, right? It is very simple and doesn't require a lot of equipment, as you see. Some of the other techniques that are described in the literature require a high-speed centrifuge, and that's why this one is a very good technique.
Are there some special patients that this might not work on?
Yes, and it's interesting because I don't know why we didn't recognize that there might be a technique available for sickle cell patients, okay? This technique does not effectively separate donor red cells from the red cells of sickle cell patients or even patients with similar hematological abnormalities. Other hemoglobinopathies and hereditary hemolytic anemias such as thalassemia. In other words, any situation where the red cells are resistant to osmotic stress.
I know that sickle cell patients get transfused a lot, and it's really important to know their phenotype. What kind of technique do you use for these people?
The next technique I will demonstrate is the hypotonic washing method.
And what is the principle of this method as compared to the other one?
Now this method is different because this is based on the ability of sickle cells, HBSS and HBSC, to resist lysis in hypotonic 0.3% sodium chloride solutions. Normal donor cells, which are either HBAA or HBAS red cells, which are not resistant to the increased osmotic stress, are hemolyzed in the hypotonic environment.
So people need to understand that there are two different kinds of hemoglobins that might cause you to sickle. Is that right?
Right.
Okay.
And that the trait individuals, the red cells of the trait individuals, will lyse by this technique because they have normal hemoglobin as well.
Okay. Would you mind demonstrating for us?
I'd be glad to. Again, you have in your handouts this technique. It's very simple. In fact, it's even a little bit more simpler than the Micromedicate technique. You need anticoagulated red cells from the patient with HBS or HBSC disease, and it should be tested within 4 days of collection. you need 0.3% sodium chloride and normal sodium chloride. And a centrifuge, and this is important, this is the only limitation, and we've got about 12 centrifuges in the laboratory, but we do have one that has on it both a high and low speed. Okay, so you will need one that has both speeds on the centrifuge. You you take 4 to 5 drops of the sample. Mix it very good. And remember that this is on a patient, a sickle cell patient, who has been recently transfused. So you will have a mixture of patient cells and donor cells. So you take 4 to 5 drops, depending on how much testing you're going to be doing. Now, of course, if you're going to be doing an auto-absorption with this, with these red cells, then you're going to need more red cells. Then you simply add 0.3% sodium chloride. Mix it well.
How many washes might this take?
Okay, let me get this loaded in the centrifuge here.
Yeah, I think you have other people loaded in there.
Right, we'll get them out. Okay. I'll use that as a balance. Here we go. Okay, we've added the 0.3% sodium chloride. You have the centrifuge still on high, and you spin for 1 minute. Kathy asked, what's that question you asked again?
How many washes will it take?
How many washes will it take? All right, there's several factors as to how many washes it will take in this. Number one, on how fresh your sample is. Now, I said that the sample should be tested within 4 days of when it's drawn. And the reason is you want to have as fresh a sample as possible so that remember, this is cells from a sickle cell patient. You don't want the cells to get older. You don't want to have just normal lysis while it's sitting in vitro. So it'll take about 3 to 4 washes, and maybe only 3 if you have a fresh sample. The second thing is, remember the procedure is lysing normal donor cells. So again, it depends on how many donors the patient was transfused with. And of course, there's no time limitation here on the time from the date of the last transfusion. But if there were a lot of donor cells, then you're going to see lysis of those donor cells, and it might take more washes. Aha! It's working. Okay, so you very gently then, and you'll notice the hemolysis. I'm sorry, I have to do this for the camera.
Yes, they need to notice the hemolysis.
Right. You notice there's hemolysis here, so there must be some donor cells in there. But there also must be some patient cells, because look there. So we actually have this many cells from this sickle cell patient, and we've lysed the donor cells, okay? Now, I won't go ahead and do the 2 more washes that it would probably take to get rid of this hemolysis, but let's just do 1 more wash and see how it looks with normal saline. So what you do, two solutions, you're 0.3%, and then you just go to 0.9%. Now, this is where it's important. Well, it's not. It is important to the point that if you've got a lot of donor cells, you need to change your centrifuge to the low speed, okay? And we need to spin then for 2 minutes on the low speed. Okay.
What about someone who has sickle cell trait? What do those cells do as compared to sickle cell disease?
All right, if you say you have a donor and you have given the patient donor red cells and you have a donor in there that has the sickle cell trait, then the red cells of the donor will lyse as well, okay, because they have normal hemoglobin. And one thing I forgot to tell you is we're spinning on a low speed at about 1400 RPMs for 2 minutes. The reason for this low speed is that if you have quite a few donor cells that you're lysing, you then have stroma that accumulates. And so the low speed then allows the stroma from the donor cells to be collected in the very top portion of the saline, and they're not down in the patient's red cells. And some reports, there have been some reports in the literature that the stroma is capable, of course, of absorbing, if you're going to do an absorption study, an antibody from the serum. So it's kind of important to try and get rid of that red cell stroma, except I'm not sure in using this technique whether we have enough stroma by this simple in vitro technique to have enough stroma that would actually absorb an antibody from the serum. Okay. And I just wanted to show you, when I took the sample from this patient earlier today, we of course had removed the plasma from it, but when we spun it down after 2 spins, we had this nice clear hemolysis. So it didn't take very long to clear it up. And we'll see how this one did. Remember that I just spun it, I washed it once with 0.3% sodium chloride, and now I washed it 1 time with normal sodium chloride. So see, we do have a little bit of hemolysis here, but it's cleared up a little bit from what it was. And you still have the patient's sickle cells in the bottom portion.
Well, thank you.
Thank you,
I
Jen.
appreciate that. Now we'll take questions from the studio audience, and as we promised, we do have an 800 number for your convenience. That number is 882-7424, and I'm sure you have questions out there for Marilyn about these techniques. While we're waiting for them to dial the number, I was wondering, have there been any reports of false negative antigen typings using this procedure?
Yes, there is one report in the literature, and I think there are maybe several others, but one that's brought to mind is in 1985, Tyler and Gonzalez reported that the reticulocyte red cells will give weak reactions with many blood-typing antisera. Now, I should point out that they used tested red cells separated by the Percol renograph technique, but they did have weaker reactions with anti-Big E, anti-Gervich, anti-FYA, JKA, little I, and anti-little e. And they cautioned that care must be taken in interpreting results. And this abstract is also in your handouts. Okay?
Okay, I think we now might take a question from the studio audience. Can we go ahead and do that?
Mark Kobuszewski, Louisiana Blood Center. Marilyn, I just have one tiny question.
Never tiny one.
Can you give us examples of specific cases where cell separation has proved useful in resolving an antibody problem?
Can I give you cases, Mark? Right, and I'm sure Mark could probably tell us a few cases too. Could I have the next slide that we have? This is an actual case from our consultation service in which we had a patient that originally at the hospital, they'd identified anti-Big E in this patient's serum. And there was a question at the time whether this patient had produced anti-little c. But since the patient had been recently transfused, they couldn't do an antigen typing. So they gave R1R1 or little c neg, little e, or Big E negative blood. And then they referred the patient to us several months later when they had noticed that the patient appeared to have produced another antibody. And this time they were getting more incompatibilities and they wanted us to take a look at it. We did a red cell separation on this patient, and the patient typed D-pos, C-pos, E-neg, and noticeably little C positive. There was no doubt with the red cell separation that this patient was not little c negative at all, and the patient was JKA negative. Can I have the next slide? Now, we suspected that the new antibody might be anti-JKA. And it was really nice because by being able to do the cell typings on the patient, we showed that the patient was JKA negative. But what's more important is now you are limiting the number of donors that can be selected for this patient, but you've eliminated that you don't have to give little c negative donors. So you have E neg, JKA negative, but you can give little c positive donors. Okay?
Okay, thank you. I think we're going to have a question in a moment. Someone called in. But in the meantime, why should a sample be tested within 4 days of collection?
Okay, there's several reasons on this, and you know, the literature says things, and 4 days is what they recommend because the sample should be fresh. I should tell you that our reference lab has had samples referred to as up to about a week old, and we've been able to do a cell separation. One of the problems is that by both techniques, the older the cells get, the less red cell recovery you have. So it's much better if you can be working with fresh samples. But if you're in a reference lab, we have it's been effective in both situations, both types, if it was up to 7 days old.
Thank you. We have a question now for Marilyn from Marilyn in Miami. Would you please go ahead?
Yes, I was interested in finding out if the technique is different if you have a patient that's been massively transfused.
Okay, the question is whether the technique is different if you have a patient who's been massively transfused. Well, it's very difficult to do it when the patient has been. Even with the 72-hour time limit, you have to do it at least 72 hours after the transfusion. So I don't know how you would manipulate it any better as far as if the patient's been transfused a lot. We would go ahead and do the cell separation, though, and we would try to look for mixed field agglutination. So that is one way that even though you might not get a total cell separation, you might be able to get some idea by doing the technique. But it is difficult.
I think now we might have another question from the studio audience. Mark seems to have a lot of questions he wants to ask us. So if we could take that one just a second.
Yeah, I have another particular question. When you chloroquine treat the reticulocytes, have you ever had problems with the cells hemolyzing or getting sticky when you're trying to remove antibody?
That's a very good question, Mark. Chloroquine treating of the red cells is done when the DAT turns out to be positive on the reticulocytes of the patient. And we have had some difficulty with chloroquine treatment not working. And I don't think it has so much to do with the technique, of course, as to the types of patients that we see someone who has, in particular, if you have a very high white count, then you really do have trouble. Yet sometimes gels. And this has to do more with the chloroquine diphosphate. So it is kind of nice to say, yeah, you can do a DAT on the autologous cells, and if it's positive, you can treat with chloroquine diphosphate, but it doesn't always work. The DAT doesn't always go negative. And as far as hemolysis goes, it's a point of debate with a lot of us, but you know, Mark, that I believe that you should do chloroquine treatment at room temp for 2 hours and not 37 degrees for 20 minutes. So it's really a point of debate on how to do it, but the best way is, of course, on a fresh sample and doing it at room temperature and not 37 degrees centigrade for the hemolysis part.
We have another question now. This person is Karen from Mobile, Alabama. Please go ahead, Karen.
Yes, Marilyn, is it very critical about the size of the capillary tube in your procedure?
Okay, the question is there a limitation on the capillary tubes and the inside diameter of it? I think the problem is that with the wider diameter that you have a little bit of a problem in separating the red cells effectively because they tend to fall down, and it gives them more surface space to fall down. Now, maybe somebody has tried this with the larger capillaries, but we have always followed the original procedure. But I would say that they have more surface area, and the spinning down one causes them to go down further rather than staying on the top part. But if you've tried it and you found different, you know, you could share that with the audience. But we have tended to stick to the original technique as outlined by the investigators, since it works so well.
Thank you.
I was wondering, how soon should testing be done after cell separation? Can it sit there for a while? Will it affect
Okay,
it?
I think that it's very critical, at least we try to do the testing the same day that we do the cell separation. So it's like I never plan a cell separation for 4 o'clock in the afternoon, right? And especially like a direct antiglobulin test, it's important to get that done. and also for the phenotyping, because you don't want those cells to sit around and you might have, since it's already been reported that there might be false negatives, then there's a possibility that you could again get even more false negatives. And on that part, I'd like to make a comment that I'd rather see a false negative than a false positive by this technique, because it means that you type the person to be JKA negative and you're going to give JK neg blood. I think the difficulty there, of course, is you are limiting the number of donors that can be given. But we don't see, I'm sorry to say that I probably disagree with that in a way. We don't see false negatives, but it is important to do the testing right away and be very careful on older samples in your interpretation.
Thank you. We have another caller. This is Susie from Pittsburgh. Please ask your question, Susie.
Hi, Marilyn. We had a question from our audience. We were wondering if you test the patient's whole blood sample and get a reticulocyte count on them, do you have a minimum percent for the patient reticulocyte count before you can use this technique?
Oh, I'm glad she asked that. That was in my notes, and I forgot to cover that.
I know.
You know, right. Okay, you were going to ask me that. Yes, well, there's not really a limit, but definitely there is to the Micromedicate centrifugation technique that if the platelet count is below 1.5%, then you do have difficulty in recovering reticulocytes to work with. Now, if it's lower than that, what we try to do then is not collect the 5 millimeters, but maybe just 1 or 2 millimeters. And that does limit the amount of cells that you get. But if that's the limitation to that particular technique, is if there's no platelet count or it's very, very low, then you don't recover young cells, do you? And so that's the limitation on the Micromatic centrifugation technique.
Thanks for that question, Susie. We now have another question. This is from Beth in Philadelphia.
Hi. My question is, do you have a problem using the reticulocyte separation technique if you have a high white cell count, even if you don't necessarily need to chloroquine treat the reticulocytes?
Yeah, we have a hard time sometimes, I think, if the white count is high, in that it's difficult to get a real good cell separation. And I'm not sure exactly why that is, other than it's a possibility that the older donor cells are getting somewhat trapped and that the white cells are not staying to the top portion. So the patients that are difficult to work with are those patients with high white counts. Leukemia patients, we sometimes have difficulty in doing the cell separation technique on. So that's another problem with the test.
Thank you. We have an active East Coast audience here. We have a question now from Carol in Tampa. Please go ahead, Carol. I think we lost Carol. Please call back and ask your question. In the meantime, I was wondering, are there some patients, some sickle cell patients, that this technique might not work on?
Definitely, and we see it quite a bit in Houston, because we have a hospital that's very active in management of sickle cell patients. And those patients who have recently undergone a red cell exchange, okay, where they've had, 10, 20 units, and it's been recent with a red cell exchange. And it stands to reason, doesn't it, because you have all these donor cells there and very, very few cells of the sickle cell patient. So that definitely makes it difficult to do a separation and get a good phenotyping.
Thank you. We woke up the Northwest, so now we have a question from Chris in Portland. Would you please go ahead?
Hi, this is Chris. I was wondering if you can use the same technique for newborns or infants.
Newborns or infants, that's a good question. And fortunately for us, we haven't had that many techniques. Now, it's difficult with the newborns in that you sometimes don't get a good separation with the Micromatic technique. But I see no reason. We haven't done that many, but I see no reason why you couldn't do the Micromatic centrifugation technique. And the same way if you were dealing with someone, I don't know how young we talk, well, newborns, as far as sickle cell disease, I don't know how many sickle cell disease patients, newborns that people have seen, but I would think the technique should work. If anybody has any comments that it doesn't, I'd be glad to hear them. But I have to admit that we have not done that many newborns in our consultation service.
Thank you. That was a great question. Susie from Pittsburgh is now called back, so we'd like to take her second question.
Hi again, Marilyn. We had another question wondering that if you're limited on samples from your patient, is there a restriction on anticoagulants that you could use? Could you go pull a heparinized sample from, say, the chemistry lab or anything like that other than EDTA?
Okay. There is my microphone on? Okay. There's no real problem with, if you're limited on sample, you certainly could go and get a different anticoagulated cell sample. So, but it should be anticoagulated. And another important thing about that is when you're talking about limitation of cell sample, as I said with the Micromedicate technique, you can then salvage the bottom portion to do an eluate from. So if you have a positive DAT, don't do the eluate first because you've already used up the cells. Go ahead and do the centrifugation technique and then use those bottom cells for your eluate. Whereas the limitation, of course, with the other technique, the hypotonic wash, is you lyse all the donor cells. So in that case, you're going to have to do your elution technique first. But you don't necessarily have to use EDTA, although, of course, cells don't stay around very well in heparin, do they, very long. So that's why we prefer EDTA cell samples. But I see no reason why you couldn't go and get a heparinized sample.
Marilyn, we talked earlier about another specific case study that you had told us about, and I wondered if you might give us some details on that one.
Right. Could we have the next slide that I have available?
This has to do with a delayed transfusion reaction, is that correct?
Right, right. Okay, this was a case study that we had in which we suspected that the transfusion reaction was due to either anti-Big E and or anti-JKA. So what we did was we separated the red cells of the patient and the red cells type D-pos, C-pos, E-neg, little C-pos. So certainly the patient could produce anti-Big E. The patient also did type JKA-neg B-pos. But I think what's neat about this is we did the rest of the phenotyping. And that's very important because that can then tell you what the patient can't produce or what other antibodies can. And you'll notice in this case the patient typed Duffy A-pos, B-pos, S-pos, little S-pos, and Kel negative. So in this case, what they elected to transfuse the patient with in the future was JKA negative, E negative, and they also selected Kel negative because I certainly wouldn't want to give this patient Kel positive blood. But then they didn't have to worry then and in the future about giving antigen negative for Duffy A, okay, or Duffy B or whatever. So if you do the cell separation, especially if you're doing it on a patient and it's a diagnosis of GI bleeder, okay, and that's important too, the diagnosis. If you know that that person's going to be around for a while, then I think there's the time to do the phenotyping. Don't just do those particular antigens.
Thank you. In case you were shy, we're going to put up Marilyn's name, address, and 800 number. So if you'd like to take a few seconds to copy that, you're welcome to contact her directly with your questions or if you need a clarification. And we'll let you do that for just a second. The last portion of this video conference will be a discussion of LIS, which is low ionic strength salt solution. Also different types of LIS additives and advantages and disadvantages of each. At the end of this discussion, we will invite you again to call in and ask questions of Marilyn. So to begin then, Marilyn, would you briefly describe the principle behind these tests using low ionic strength salt solutions?
Several factors influence antigen-antibody reactions: pH, temperature, and ionic strength of red cell suspension media. It has been established that incubating serum and red cells in a reduced ionic strength medium increases the rate of antibody uptake. Low and Messiter in 1974 had the first practical application of the principle in routine antibody tests, using a low ionic strength solution at an optimum sodium chloride morality of 0.03 instead of physiological saline as a suspendium media for red cells in the antibody test systems. This permits increased sensitivity in some, if not most instances, with decrease in incubation time and no significant increase in incidence of non-specific reactions. The procedure enhances antibody reactions, especially at the indirect antiglobulin test.
Marilyn, what is meant by Liss additive solutions, and why have these become much more popular than Liss suspended cells?
Okay, could I have the next slide up? And I put this up so that you all would sort of get a feel for what we're talking about as far as the three different types of Liss or whatever that we're talking about. An alternative to the low and Messiter procedure of red cells suspended in an isotonic low ionic strength solution is to use a solution that is added to a mixture of serum and cells in physiological saline or some other normal ionic strength suspending media. The ionic strength is approximately equivalent to that achieved by mixing equal proportions of human blood serum and red blood cells suspended in Liss, which is the first technique listed of low and Messiter. The use of additive solutions have come popular in use in place of Liss suspended red cells because it does not require preparation of the test cells prior to use, especially in antibody identification tests where the panel of red cells can be used as supplied by the manufacturer and do not have to be resuspended in Liss solution.
What is the difference then between low ionic high molecular additive solution and low ionic strength additive solution?
Kathy and I have trouble with these. We have to go slowly. Okay. In 1978, Rosenfield reported that incubation of low ionic strength, followed by the addition of polycations, promotes direct hemagglutination by many blood group antibodies, thus facilitating their detection prior to the indirect antiglobulin test. The low ionic, high molecular additive solution is somewhat based on this principle, but incorporates the macromolecular additives directly into the Liss solution. This solution potentiates direct agglutination of antigen-positive red cells by some immune antibodies, as well as increases the sensitivity of the antiglobulin test. Now, the other low ionic strength additive, relies solely on low ionic conditions to enhance uptake of antibody, to facilitate detection in the antiglobulin phase of testing. This additive solution does not contain macromolecular potentiators.
So what are the advantages, disadvantages, and limitations of each of these solutions?
Okay, in general, both additive solutions improve the rate of association between many blood group antibodies and their corresponding antigens, enabling incubation times to be shortened to 10 to 15 minutes instead of the routine 30-minute for albumin. Several studies have definitely shown that Liss test results are better for clinically significant alloantibodies than albumin tests done with shortened incubation of 10 to 15 minutes. Okay, can I have the next slide? Great. The low ionic high molecular additive solution has the advantage over the low ionic strength additive solution in that many antibodies will give direct agglutination with this additive solution incorporated in the test. This can be useful in antibody identification tests with, for instance, mixtures of alloantibodies. A pattern for anti-Big could be very obvious on immediate spin and or at 37 degrees, whereas in the antiglobulin test, the anti-Big pattern could be less obvious if another antibody is reactive at this phase of testing also. At the antiglobulin phase of test, there is no benefit derived from the presence of the macromolecular potentiators, as the effectiveness of antiglobulin serum in causing agglutination of IgG antibodies is not based on shortening intercellular differences. Instead, it is based on cross-linking of red blood cells that have become coated with antibody during incubation. And since incubation is at a low ionic strength, the rapidity and strength to which red cells become coated with specific antibody is enhanced. The disadvantage is listed on the slide, well actually there's probably two, of this additive solution is that the use of too great a concentration of polycations may result in non-specific aggregation that could be mistaken for true agglutination. And this occurs especially at the immediate spin phase of testing if you do it and the 37-degree phase. Also, the use of serum that is diluted with saline, such as some of the surveys or tests for students might be, this may also result in formation of what I guess most people would call rouleau, and also if you are testing eluates with this particular reagent.
Is there a disadvantage to using the low ionic strength salt solution?
Okay, now remembering that this one does not have the potentiators added to it, so if you have to keep in mind, we're switching back now to the other solution. There's no real disadvantage to the use of this low ionic strength additive solution, but there are several limitations to the test. And can I have the next slide, please? It has been reported that Abo incompatibility is reliably detected by the antiglobulin test performed under low ionic strength conditions after incubation at 37 degrees centigrade. And if you'd like to read this reference, I don't have it in the back handout, but it's in Transfusion. In 1983 it was published, volume 23, page 237, and it was by the authors Trudeau, Judd, and Butch, and Oberman. However, if you desire to do, if you don't believe this report, and there is some debate on whether LIS detects Abo incompatibility, what you can do then is to go ahead and do your immediate spin for Abo incompatibility and then add LIS and go on to 37 degrees and complete the test. Or you can set up a separate tube and do an immediate spin or room temperature for Abo incompatibility. The volume of LIS additive, okay, is very important. That the volume that is added to the serum being tested must be exactly what is indicated in the directions for the use of the additive. Okay.
In summary, then, why do you feel a LIS additive test should be done in place of saline or albumin testing?
Well, it's hard to make a change, isn't it? And albumin has been the method of procedure for a long time. But I do think that LIS is a very good technique for two reasons. We have seen very much increased sensitivity, especially with alloantibodies in the KID system, for instance. And we also know that this can be done, the testing can be done in 10 to 15 minutes. And that's a decrease in time incubation. And when we're trying to get the blood out for the patient, 10 to 15 minutes is a lot better than 30 minutes. And if you are using an albumin technique for your detection, it has been shown, studies have shown that 20-minute albumin is not long enough, that you could miss some clinically significant antibodies. So a 30-minute incubation should be used with albumin, but why do that when you can use LIS for 10 to 15 minutes? And I think that a lot of laboratories have switched to doing that routinely.
Thank you.
Thank you, Kathy.
Now it's time to hear from you. Again, the 800 number is available, and that is 800-882-7424. please call in and ask Marilyn your questions about LIS or any of the cell separation techniques. I was wondering, does the addition of LIS to the test system enhance autoantibodies as well as allo or other non-clinically significant alloantibodies?
Right. And as with every procedure, of course, there's the disadvantages that go along with the advantages. And in the handouts that I gave you, which is the last page, I've given several references to studies done on the use of LIS in routine detection and identification tests, and also comparison to other techniques. So I would like you to, if you can at some time, take this reference home and look at it to see what the different studies showed. But in my rush to get this list off to ABB, I inadvertently left off, and probably the authors of these papers would maybe be in the audience and remind me of them. But I left off 3 references dealing with LIS panagglutinins or autoagglutinins of no apparent clinical significance. And 2 of these were abstracts from the ABB meeting in 1981 of studies done by Morell and Tyler of the Los Angeles Red Cross, and another one done in California as well. These 2 people, and you can find the abstracts, these 2 abstracts can be found in the 1981 list of abstracts from ABB. Now, the last authors published in Immunohematology, which is the Journal of Medical Technology, their results, and you can find that in the issue in July 1984. And this article is titled, LIS Panagglutinins Interfering with Compatibility Testing. Now, in all cases, transfusion of blood products incompatible by the LIS method, but compatible by the standard albumin method, did not result in observable signs of a transfusion reaction. And I should point out here that these LIS autoagglutinins the problem with it is if you don't know that they exist, that you can actually delay transfusion to the patient. You do your test by LIS. We've told you that this is the best way to go, that antibodies are enhanced in a lesser amount of time. And then you turn around and you find this antibody that's coming up, immediate spin or 37, whatever technique, and it causes an incompatibility. And if you're not doing an auto control, then this really creates a problem. So there is a limitation with the test that there are LIS autoagglutinins.
Thank you, Marilyn, for that answer. We now have a phone call from Kathy in St. Louis. Go ahead, Kathy.
Okay, it's Kim. You stated that in the Micromatic red cell separation technique, the specimen of choice is an anticoagulated specimen. If you only have a clotted specimen, could you use that specimen if you freed the red cells in some way, such as passing it through a filter?
Well, that's a good question. I'm not sure that you would get an effective cell separation. I think that the younger cells could actually be trapped into the clot. To be quite honest with you, we don't try it. That we've always tried to get an EDTA or an anticoagulated cell sample drawn. Now, if anyone's tried this, feel free to call in. But I would guess that the technique doesn't work very well because you could have the red cells actually trapped in the clotted portion. I think you could have some discrepancies with that. Has anyone tried it? Is there anyone, if you have and it worked, it would be nice for us to know that. But I have to be honest that we in our laboratory definitely feel that if you've got the patient there and you want a cell separation done, that you should go collect an EDTA or an anticoagulated sample on the patient. If they're difficult to stick, then that's another problem too, but maybe, as someone suggested, you could go to chemistry and see if they have a sample. But if anybody's tried that technique, but I would say, just my gut feeling is that it would not work if you didn't have an anticoagulated sample.
Thanks for your question, Kim, and sorry about the mix-up on the name. We now have a question from our studio audience. Would you please ask it?
Marilyn, I'd like to get back to LIS autoagglutinins. I have a 2-part question.
Okay, Mark.
The first part is, are these autoagglutinins IgM antibodies or IgG antibodies? And the second part is, do they have any particular blood group specificity?
That's a very good question. Both of those studies had different results. One of the studies showed that 3 out of the 4 serums actually were IgM antibodies. So, of course, the reactions were better on immediate spin and 37 degrees centigrade. And if they used IgG Coombs, only one of them showed very weak reactions in the antiglobulin phase. The other study showed just the opposite, that the patients they were dealing with had antibodies that were IgG and came up in the antiglobulin phase using anti-IgG. And I have to be very honest with you that I think that what they were detecting in the latter case where it was IgG is they were detecting probably maybe the first appearance of a warm autoantibody. And that definitely would be an IgG antibody. And I don't think too many people with LIS, if they're using LIS, are going to see the IgM ones because the LIS isn't really conducive to detecting IgM antibodies. The LIS additive solution. Now, if you're the low ionic strength additive solution. Now, if you're using the one with polymers in it, though, then just the opposite is seen in that you might pick them up because on immediate spin and 37 degrees, those polymers are going to pick up those cold agglutinins. And that's why it's important, as I went through this today, for you to realize there are 2 different types of additive solutions, and they do 2 different things. So you need to know which one you're using and the advantages to them. And yes, some of them have shown blood group specificity, Mark. We've had an anti-JKA that showed this specificity. And we also had an anti-Kel. And it's interesting, they say that some of the early reports say that anti-Kels were missed by using a LIS additive. We find just the opposite. We find them coming up in a LIS additives that has the molecular substances added to the potentiators on immediate spin and 37. So it's not been our experience that those were limitations to the test.
Thank you, Mark and Marilyn. We have a question now from Milwaukee with Sue. Please go ahead with her question.
Hi, thank you. Actually, I have 2 questions in regards to the LIS additive. The first question is, what do you recommend for routine use in pre-transfusion testing? Do you recommend the use of anti-IgG or polyspecific anti-human globulin? And in addition, in the antibody screen, do you recommend reading the screen microscopically?
2 very good questions. And it also brings up a point, too, about the LIS additives. Some people might ask, which one do we use routinely, for instance, in the reference laboratory? And I think it really depends on your institution and the technologists that are using it. But on a routine basis, for antibody detection purposes, I think that you're very safe in using the low ionic strength additive without the polymers added and using IgG Coombs. Because remember what I said, that it's very much increased sensitivity, okay, in a less amount of time. So that IgG Coombs will then pick up the clinically significant antibodies and using this LIS additive. But the other additive with the polymers can be used as well. We like to use, in our antibody identification in the reference laboratory, we prefer using the LIS additives that has the polymers added. And it goes back to the case I showed you where on immediate spin or at 37 degrees, you'll see this beautiful pattern for anti-big E or anti-little c. Then you get to the antiglobulin phase, and here's other reactions. Well, at least you know the anti-big E is there. And then you can work around that in what's in the antiglobulin phase. With the LIS additive solution without the polymers, you don't see that much enhancement at 37 degrees of IgG antibodies. So it's primarily for the antiglobulin test.
Okay. We next have a question from Atlanta. Kenneth, please ask your question.
Actually, I don't have a question. I have a couple of comments. The first comment has to do with the use of clotted samples. in our reference lab here in Atlanta, we've had some considerable experience using them. We press the cell clot through a sieve, collect those cells, and then wash them until hemolysis is clear. The cells seem to survive very well, and we've had very successful cell separations. We can tell this by comparing RH typings, for example, on the pre-sample and the post-separation sample, and we've had very good success, so I would recommend that these samples be used. We've also had luck because you can recover quite a fair sample of red cells from those clotted samples, and if you're trying to do autoabsorptions with those collected cells that are separated, you have a considerably larger sample to work with than you do if you're just using EDTA cells. In addition, the cells seem to store much better. They have not been placed on any anticoagulant, and in fact, we've been real happy with the use of clotted samples for those techniques. One additional comment has to do with white cells. We noticed a number of years ago the problems that you have if you've got white cells present when you're doing a cell separation. And if you initially do a light spin when you're doing the washing, you can in fact remove the white cell layer carefully without removing a lot of reticulocytes. If you've done a simple, a very light spin on a large washed tube, and that's been helpful to alleviate some of the problems with the white cells.
That's very good, Kenneth. Well, I'm glad to hear that with the clotted samples. It requires a little bit more manipulation. And I only have one question about that. You said it stores well. I think that's good as well, but never store it in saline if you do. You should store it in a preservative solution, because I think then you run the other risk of getting false negative reactions just because of stored samples in a saline solution. The second point on that is that I think we tend not to deal with clotted cell samples very much because of complement and the false reactions you're going to get with complement binding in vitro. And remember, on the Micromedicate, we're doing an evaluation of a positive DAT, and most of our cases deal with positive direct antiglobulin tests. And we're trying to figure out whether it's a transfusion reaction or whether it's an autoantibody that's coating the red cells. And frequently in our reference lab, we see anti-JK, for instance, that not only has IgG but C3 on the red cells. So I think, Kent, don't you have a limitation on clotted samples that you get false reactions in vitro with complement? So that might be the limitation. I guess I'd kind of forgotten that in the back of my mind, why we don't use clotted samples, because the anticoagulated samples give you the best results in evaluating the DAT. Same way with warm autoantibodies. You don't get them very often, but there are the warm autoantibodies that will show both IgG and C3 on the red cells. And I think the anticoagulated sample then is the method of choice.
I might suggest that he call you on the 800 number tomorrow when we get back.
Right, that's a good idea.
And you can discuss it in more detail. Meanwhile, we have fortunately found Carol again from Tampa, and we'd like to hear her question.
Okay, I have two questions. The first is to Marilyn, if you've noticed any disadvantages of Micromatic centrifugation as opposed to using phthalate esters. The second is if you've noted any difference in reactivity of HTLA antibodies using LIS as opposed to albumin.
Question. Number one, throw your phthalate esters away, because they're very much of a hazard from what I've been told. And when we tried to dispose of them, everybody was, cautioning how we were going to dispose of the phthalate esters. Now, you know that we sent these out years ago so everybody could use them, and we did use them. The problem with the phthalate esters is that you have to do all these different specific gravities, and then you end up with just a few cells. It was more of, I guess, an evaluation of the immune process. But I saw no difference, and the comparison studies that had been done in the literature saw no difference between the cell separations done with the Micromatic over the cell separations done with the phthalate esters. It was just a technique that came out first. Okay, the second part of the question is, have we noticed any difficulty with the HTLA antibodies in list detection tests or identification tests? And that's a very good point, because a lot of investigators are saying, great, we don't see these HTLA antibodies as much. And that's probably true, because it stands to reason that you're only giving that high titer, very low avidity antibody only 10 minutes to react, aren't you? Because we're all doing our detection tests in 10 minutes. They don't like that. They'd rather have 30-minute incubation, okay? So, and they're not clinically significant. The majority of the HTLA antibodies do not cause rapid red cell destruction. So if you miss these HTLA antibodies, you're probably very fortunate that you do, instead of doing the albumin. Now, we use the albumin technique 30 minutes to 60 minutes to identify HTLA antibodies and rule out other antibodies. But if we do that for you, then go right back and do your routine cross-match with LIS, okay? Because you want to find cross-match compatible blood or the weakest reactors or whatever. Don't do your cross-match in albumin for an hour. And that's more of the identification process. So I think you see less reactivity. The only HTLA antibody, unfortunately, that loves LIS, and that is BG antibodies. You know, they are high titer, low avidity. They're not high frequency. They're not directed at a high frequency antigen. But they do like the LIS media, and not so much in a way the shortened incubation time, but certainly you would detect it more than the other HTLA antibodies.
Thanks for those questions. Sue in Milwaukee has a second one, so please ask your question, Sue.
Thank you. I was just wondering if you could address the second part of my question in regards to the microscopic reading of the screens.
Oh, I was going to avoid that one, right. Yeah, I hear the laughing in the background. Well, John Judge should be here on the podium with me, I guess, discussing should we reuse the microscope or not. It's interesting in that this has been under debate for a long time, and I know that laboratories routinely in antibody detection tests do not read reactions microscopic. Now, as I said before, the LIS technique does pick up panagglutinins, BG antibodies, and things like this. So if you do not routinely use a microscope in your laboratory and you switch to LIS additives, then you will probably have less problems, perhaps, than a laboratory that does use the microscope. But I don't think anyone who uses the microscope has a problem, because if you're like me, you do it so much that you get a feel as to what is a weak reaction that's probably not clinically significant, or an antibody that is coming up, for instance, very weak. It's macroscopic with homozygous cells, but microscopic with heterozygous cells. So at least in a reference laboratory situation, at least our reference laboratory, we do use the microscope routinely. One thing I do want to bring up, this microscope business, is a lot of people are still reading under the microscope using a slide and pouring onto the slide. And you say, oh, no, but they are. If you're using the microscope, I recommend the tube technique. And I'm one of those. You have a tube holder, and you can either use a 10 by 75, which I use, or a 12 by 75. And you roll the tube and look at it under the microscope. And since, you know, I didn't switch, it's been only about a year since I quit pouring on the slide, but the girl said, you've got to sit down and do this, Marilyn. And so after 25 years, I started rolling the tube. And you can get a feel for the agglutination. You can look at rouleau. For instance, you can look at anti-SDA, and we're talking about antibodies now, and getting away a little bit from LIS, but by using the microscope in an identification process, you can say, oh, that looks like SDA. So I don't say you have to use it routinely, but I certainly feel that, you know, you can use the microscope very safely, even if you're using LIS additives. And I still do.
You did answer her question.
Yes, I was avoiding it.
I'd like to remind you again, if you'd like to call in, the number is 800-882-7424. And now we'll take another question from Susie in Pittsburgh.
Thank you. I was wondering, Marilyn, if you can comment on the sensitivity of LIS as far as the volume used, in that we know you have to follow manufacturer's instructions, but have you had any kind of experience in that, like if you hold the Liss dropper at, say, a 45-degree angle and get a larger drop versus straight up and down getting a smaller drop, have you gotten false positives with that small of a variation in volume of Liss? We have a site here that's basically what they tend to attribute their false positives to, is that minute amount of volume of Liss may be causing them some problems. We're wondering if you could comment on that.
Oh, you took Kathy's question away.
It's okay.
And we're very glad you did, right, because that is one of the points we did want to cover. It's very important to follow the manufacturer's directions if you are using a commercial product, for instance, that is a Liss additive. I think what's important here is that it's in-house. It's got to be in your own laboratory, and it's got to be quality controlled. And there is a lot of variation between the actual dropper that is included in each manufacturer's Liss additive. So the dropper can definitely vary from the dropper you're using in the laboratory to add the serum to the test. And for instance, in our laboratory we have two different types of droppers. One of them delivers a smaller amount than the other one, and we like to use it, say, for cell suspensions, and then the other one delivering the serum. And it can very well be that if the test procedure says use 2 drops of the patient's serum and 2 drops of the Liss additive, that in your laboratory, if you calibrate your pipette, you will have to use maybe 3 drops of serum and 2 drops of additive. Okay, so you definitely have to do some calibration in your own laboratory and determine, and always use the same droppers then for delivering the serum. And if you get it in a different type of dropper, if you're supplied by the different manufacturers, then you really need to do the quality control on each set of droppers that you get in. And as far as non-specificity, it's interesting you should say that, because if you do not use the right volume of serum and additive, you frequently get false negatives. So because you have altered the ionic strength and you're not having the optimum test conditions. So I'm a little bit surprised that the reactions are actually false positives by having this ionic strength off. Perhaps maybe it's a matter of, I don't know the situation, but it seems to me more often the false positives are due to the use of polyspecific anti-human serum versus IgG anti-human serum, rather than just Liss per se. Either that or the hospital is very unlucky in getting some of these Liss autoagglutinins.
Speaking of, excuse me, the technique of it all, is there a specific order that you should add these things in?
Oh, that's very good. Definitely there's, you know, it's the old thing, if I remember correctly, that we always were supposed to add our red cells, and so that we could see the red cells, test cells, were in the tube, and then we added the serum. And that way you knew you had added the red cells or the serum, vice versa. But when you come to the Liss additive now, the thing is the order is very important, in that you should add the red cells and serum together first. Don't add the red cells directly to the additive and then add the serum, because you will get lysis of the red cells. So it's very important to have had your red cells and your serum together first, and then add the Liss additive as the last addition to the test. That's very important.
I'd like to switch gears on you just a little bit, since it's
terrific.
quiet out there in the studio audience. Getting back to the red cell separation techniques, I was wondering, if someone is multiply transfused at different times, maybe a week or 2 weeks apart, does that have a bearing on how your cells will separate?
That really doesn't have too much of a bearing, because the first transfused cells, of course, are the older red cells, and they'll be to the bottom. And then the next transfusion. I guess what goes back to what's really important here, at least with the Micromedicate centrifugation technique, is that it's drawn at least 72 hours after the last transfusion. Now, and of course, with the hypotonic wash, that's not that much of a problem. But I would guess that well, I wouldn't guess. The older cells from the previous one would be older and have a higher specific gravity, and they would fall to the bottom. But you have to have this second transfusion at least 72 hours before you draw the sample.
Okay.
And that is a limitation to it, because but most of the time you're dealing with delayed transfusion reactions. We find a lot, and it's after 72 hours. If you're dealing with an immediate transfusion reaction, it doesn't work, does it? So, but most of our cases where we do micromatic centrifugations, they're actually done as a delayed transfusion reaction workup. And somebody asked me, how many would I do in the hospital? If you were in a routine hospital and you had to work up sickle cell patients, for instance, you might do, one a month or whatever, or one a week. But it's important that you know that the technique's there and that you can do it. And especially if you know that this sickle cell patient now hasn't been a problem, but now is coming in more frequently for transfusions, and you never did get a pre-phenotype. A lot of people actually type their sickle cell patients before they get transfused a lot, so they know what their type is. But all of a sudden you've got one coming in, and that's the time to do the cell separation technique. But, and how many, we do one a day probably in our reference laboratory, because most of the patients we get referred to us are recently transfused individuals.
Thank you. I guess I might tell the audience how I remember where cells go when you spin them down. Since you do one a day, a lot of people probably don't do that many. I think it's like with humans, the older you get, the heavier things go to the bottom. So perhaps you can remember that. It helps me. Since we only have a couple of minutes left, I wondered if you might, Marilyn, summarize the difference in the two cell separation techniques and the different kind of Lys additives. We just have a couple minutes, but I think we have time.
Oh, great, good. Yeah, I think it's, am I falling out? I think it's important to recognize, first of all, the diagnosis of the patient you're dealing with, and that knowing that the Micromedicate centrifugation technique is the principle behind it, is the older cells fall to the bottom, and you have the younger cells at the top. And you're trying to recover these cells to do phenotyping, autoabsorption, direct antiglobulin test evaluation. With the other technique, it's for sickle cell patients or patients that have similar abnormalities in which they're resistant to the lysis by 0.3% sodium chloride. And the difference between the different Lys additives, there's no reason why you can't use Lys suspended red cells if that's what you want to do in your laboratory. But the additives make it much more convenient because you don't have to manipulate the red cells. The low ionic strength additive enhances reactivity in the antiglobulin phase in a decreased amount of time. The Lys additive that has the polymers added the advantage to it will cause direct agglutination of some IgG antibodies at 37 degrees, and also, of course, reactions will occur in the antiglobulin phase. So it's very important to remember that we have these solutions available and that you need to evaluate them in your own laboratory. And if you get too many false reactions that you call false reactions with one technique, then try another one.
Thank you. I would ask the studio audience to please fill out your evaluation. The Continuing Education Committee is meeting Friday. We're going to set up the programs for the following year. We'd like to know what topics you're interested in. If you like audio or video, please let us know, because we really truly do read those and take them into account. I'd like to very much thank Marilyn Moulds and Gamma Biologicals Incorporated for allowing her to be with us today. I think you did a great job. I learned a lot. I very much appreciate you being with us.
Thank you, Kathy.
Also to the Louisiana Blood Center, they're always a wonderful host for us, and we thank them very much for their hospitality. As well, Alternate View Network and Jack Easterwood for taking care of the technical end of this production. Also Jean Otter and Tanine Carvel, who are the ABB staff who helped put this program together. And lastly, to you, the audience, we very much appreciate you being with us today, and we wish you a good day.